talking about distribution. So with distribution of a drug, many factors are also going to help how the drug is distributed and redistributed in the body. So distribution, as we know, after the first pass metabolism, it should be distributed to various tissues, and for that, the factors which are responsible are it should be either lipid soluble, it's the blood flow to the organ is important, the capillary permeability to the organ is important, how it is being distributed. For example, is it distributed with a protein, or is it what is it protein bound drug? All these things are important. And another important thing is volume of distribution. See, the volume of distribution is an imaginary hypothetical number, hypothetical volume of drug, that it is the hypothetical volume of drug that is required to achieve the plasma concentration of the drug. So volume of distribution is equal to amount of drug in the body, however you give route of administration, divided by plasma concentration of the drug, that is plasma concentration of the drug that you achieve. So the volume of distribution, if this volume of distribution helps us in telling us where the amount of drug is present. Is it present in the blood, or is it present in the tissue? Now, if the volume of distribution is, if the amount of drug in the body is more, that means the volume of distribution is more, which means it is going, there's more concentration, volume of distribution is more to achieve the required concentration. So the volume, if it is more, it means it is more going towards the tissues. If the volume of distribution is less, which means all this amount of drug is being achieved, is being present in the blood itself. It is not being distributed anywhere else. So the volume of distribution itself is also has many factors contributing to it. For example, first factor is protein binding. If you have a high protein binding, then the volume of distribution will be more. If you have a protein binding to the tissue will be more, then the volume of distribution will be less. At the same time, if it's lipid soluble, it will be easily distributed to the tissues, so it has high volume of distribution. Now, what are drugs with high plasma protein binding are warfarin, diazepam, and also we have digoxin. We also have digoxin. We also have valproate, sulfonamides, phenytoin, SSRIs like fluoxetine, morphine is also bound to albumin. Now, what is the most important thing is that all these things are bound to albumin. So acidic drugs will bind to albumin, and basic drugs will bind to alpha-1 acid glycoprotein. So if there is any heart, liver failure or renal failure, all the proteins will be less. So the toxicity of the drug will become more. So in one way, volume of distribution also tells us the dose that is required during the liver failure and renal failure. Now, and also if you have high protein binding capacity, then you should not dialyze these drugs, because in dialysis only free drugs are going to be excreted, not the protein bound drugs. So again, the same thing, diazepam and digoxin, kerosene, amphetamine and verapamil, calcium channel blockers, amphetamine, opioids, ibuprofen, all these drugs can also be not excreted in dialysis. So that is, and also if there's also certain things. So if warfarin and sulfonamides are both bound to the proteins, albumin, but if sulfonamide and warfarin is given, then sulfonamide will displace and attach to warfarin, so there will be more of warfarin toxicity. Similarly, if sulfonamide with high bilirubin is there, it will displace bilirubin and you will have kernic stress. Phenytoin will displace warfarin. It will also have warfarin toxicity. Similarly, sulfa drugs are contraindicated in pregnancy, because again they can cause kernic stress because of the same reason. That is why these protein binding capacities can just displace each other by causing toxicity of the opposite drugs. So this is distribution.